Good afternoon, everyone. Thank you for joining us today for the next installment in Grensbach Lear & Associates webinar series, Engaging Physicians in Fundraising, Diagnosis and Treatment. Today's webinar is co-presented by Ralph Silverio, Vice President and Managing Director of GG+A, and Linny Meyer, Chief Development Officer at Norton Healthcare. Our presenters welcome any questions you have during today's session, and we'll answer those questions in the time remaining at the end of the hour. To address a question to Ralph or Linny, please use the chat function on the right-hand side of your screen, select all participants or all panelists from the drop-down menu, and send us your questions. Any questions we did not answer today will be addressed in a follow-up message we send out next week. Tomorrow afternoon, we'll also be sending a recording of the session along with the presentation slides, as well as a short survey to gain your feedback. Thanks again for joining us today, and I'll now turn it over to Ralph to get us started.
Thank you very much, and thank you all for joining us today. I am very, very pleased to have as my co-presenter Linny Meyer, who is the Chief Development Officer of Norton Healthcare in Louisville, Kentucky, where she oversees the Foundation for CoSare Children's Hospital and the Foundation for the Norton Healthcare hospitals, which are four tertiary and community hospitals. Linny has an extraordinary background because not only is she an expert fundraiser, but she is probably one of the few nurses to obtain that kind of stature within our business. And if there's anyone who knows about the inner workings of a medical facility and a medical center, it's Linny. Linny, thank you for joining us. Just to inform our guests, you are in a campaign for the Children's Hospital at CoSare, is that correct?
That's correct. Our hospital has a history that dates to 1892, and we're actually completing the first growth plan in our 100-year history. It's a $205 million goal, and we're knocking on the door of it. We are about $4 million from goal. We think we'll surpass it this year and wrap up the entire campaign by December. In terms of my background, I've been involved with fundraising for nearly 30 years now, and much of that with healthcare institutions. I was the Senior Vice President for Advocate Healthcare Foundation when they did their big campaign several years ago and got back into consulting. And prior to that, I'll warn you ahead of time, I was actually a hospital chaplain. So I got to know the strengths and vulnerabilities of our medical staff very, very well. So if over the course of the day I'm a bit preachy and overly sympathetic towards physicians, you know where that's coming from. We have titled our presentation today, Engaging Physicians in Development. This is really focused on development staffs and our role in trying to persuade and engage physicians in the development effort. We've subtitled it Diagnosis and Treatment, not only to be cute, but to really get everyone thinking about, very much like a physician, about what does our patient really look like, and what are the best practices that we might have to encourage their involvement. So what we're going to attempt to do for you today is to put things in context. That's sort of the diagnosis. Look at the context and conventional wisdom, and then move to best practice, and really go from the macro, and that is how to inform physicians at the medical staff level, and then to the micro, how to engage physicians one-on-one on a more personal level. So we thought we might start with, just for your own information, if you haven't seen these, the new slides given by Giving USA have just come out about 2 weeks ago, and we just included several of them in the presentation. I'll run through the ones here in case you haven't seen them. What's the latest up to 2010? You're familiar with, I'm sure, with the layout, and I would hope that all of you, when you're engaging your administration, your lay volunteers and your physicians are using this kind of data to support your position and get them more knowledgeable about the way development works. This third slide, which really indicates that individuals give the most philanthropy, to me is the most valuable of all the slides that we present because it's the best educator when it comes to major gifts fundraising. It is interesting to me that we still get, when we present this slide, oohs and ahs from volunteers and even administration, certainly physicians, because they think that most of the money comes from foundations and corporations. This is the most up-to-date slide in terms of cash donations per bed by institution, and I know today we have represented academic medical centers, children's hospitals, community, and systems. It's interesting to me, we just were able to incorporate this slide. The one from 2009 actually had specialty hospitals broken out, and that would include places like MD Anderson and Sloan Kettering. And you notice they're not in it this year because their response to the survey was so minimal they couldn't get they really couldn't represent it. So I guess those institutions are too busy fundraising to participate in the survey. But this is what we have, and I think it makes the children's hospitals look a bit better because some of those were actually listing themselves as specialty hospitals. So last but not least, we want to be aware of what the national picture is in healthcare and some of the real negativity surrounding healthcare right now that the general public is aware of and open to day after day. Linny, in your experience, are these areas and are these concerns are they present among the medical staff and physicians? Do they get influenced by this kind of negativity?
I think that physicians are hearing it in their offices, so they're keenly aware of these challenges. Many of them feel it themselves as we look at reform, and they're doing more with less. So I think that's an important opportunity for us to kind of reframe the dialogue.
Thank you. Let's look at the conventional wisdom that most of us adhere to when we're talking about physician participation in fundraising. I think we'd all agree that we still view, and will keep on viewing, the physician as the keeper of the key in terms of grateful patients and in terms of their ability to legitimize fundraising to a larger audience. Lenny, I always think back when I see information like this to our campaign committee where one of your extraordinary physicians was involved, and every time he would speak, everyone would listen, and he would really, really grab the ear of all the participants in the room. I'm talking about Dr. Wolf.
Dr. Wolf was a highly credible physician who spent his entire career at our children's hospital. He was the retired medical director, and he was also a donor. And he joined our campaign leadership cabinet and really did help set the tone with the lay leaders around the table. Any program vision, any idea about growing a service, anything that came into the case for support, if he spoke to it, the committee embraced it. And I think they felt more energized by having him around the table. He is an annual donor, he's a major donor, and he has made a testamentary commitment through his estate. So they're able to see every dimension of him in terms of where they fit within the giving paradigm. And I think there's no question that the credibility he brought as having been a medical provider was key to that.
Let's look at some of the assumptions, and I would call these gross assumptions and expectations of physicians that we commonly hear from administrators, volunteers, and even fundraising staff. And I'm sorry to say that many of these are still in play when we engage with healthcare clients. there's, especially within community hospitals that might be engaging in more aggressive fundraising or fundraising for the first time, there's this idea that physicians are obligated to participate in a fundraising process, not only as donors but as volunteers. And one of the big assumptions in bullet 4 there among our academic medical centers is that somehow the heads of departments and the chairs will automatically or are obligated to positively influence their colleagues in the department about fundraising, and that somehow this happens by osmosis or miracles or whatever. But we see it as a fairly common practice. And of course, last but not least, physicians as a source of significant gifts. They will do it. As we all know, all physicians are rich. That is at least an assumption among many of our clients. So we're going to sort of conclude our context with talking about what the physician's world is. And we would ask you to think about these critical questions, which we're going to ask rhetorically as we work our way through the presentation. But does our respect and admiration for physicians and our medical staff really translate into actions, appropriate actions to engage their participation? Are we really thinking about them as the special volunteers that they are, and not as part of the family that's automatically going to be linked into this and that they have an obligation to do it? And finally, how do we explain ourselves to these really, really important and extraordinary people? Do we do it in terms that they understand, or do we do it with our own lexicon and jargon? Granted, they have theirs, and it's difficult for us sometimes to understand it, but we are obliged, certainly, to report ourselves and explain ourselves in language that can be understood by physicians. So what might we agree on that are the roles and responsibilities of physicians? If they have an obligation that we can all agree on, I would think it would be to provide the best diagnosis and treatment possible for the patients in your institution. Or if they're MD, PhDs, to provide the best research that will lead to cures. It's certainly not an obligation to participate in fundraising. We know that they're incredibly intelligent, trained, and focused individuals, that they are working harder these days for probably less money, and they are very, very concerned about their position within healthcare delivery as we move forward. Lenny, any comments about the questions we asked and about these roles and responsibilities of physicians?
I think the big comment I'd have at this point is on the 4th bullet, to think about their role and what's happening in systems across the country as it relates to reform and quality and the drive to develop accountable care organizations. That our system, like many other systems across the country, has brought that physician leadership to the table to be a partner in ACO modeling and in looking at quality and looking at outcomes. And so I think there's a real opportunity to reframe the frustration and to help them feel like they have a voice in or a stake in the vision, the programs, and the services and how they're being shaped. And I know you're going to get to that, Ralph, on the next slide, but I think it's really important to keep that in mind, that we have the opportunity as development officers to really set a tone in a more positive way.
So on to the next slide, Lenny. Thank you. Let's talk about what the physician's relationship are with hospital systems and academic medical centers. We know that it's becoming increasingly contentious. Certainly the doctors' practices are in direct competition with hospitals and systems. And in the academic medical centers, the competition for resources is reaching incredible degrees of combativeness and in some cases, desperation. So as NIH fund and other grants begin to run out, what's the attitude of physicians? They can be loyal to the immediate institution, but they can mistrust the administration and really dislike systems. Many physicians are influenced by the fact that the organization or institution that they work for are perceived as having deep pockets. It's very true with systems. There is a generational fracture among physicians. The younger physicians are looking with almost envy at their older colleagues who may be near retirement and have made it in what they think is under an easier aegis. And the older physicians are scratching their heads about what is everybody complaining about, and where's the loyalty among the younger doctor staffs. They also look at the younger generation with awe. They find them to be incredibly educated. The argument that we get the most among physicians, whether it be academic medical centers or hospitals or systems, is they are not involved enough in the future of the direction of healthcare. So I think these are important to remember, because if you are a development officer, particularly a new one, and engaging with physicians for the first time, and you go in and the physician seems to have a chip on their shoulder, you may know where it's coming from. So we have an obligation to understand these issues. There's been a number of young development officers that we've seen that have had psychological lobotomies by physicians as they walk in, and they really wonder, what did I say to bring out this kind of concern about the future of healthcare, and the anger that's expressed with many physicians. These are questions that we've gathered over the years in asking physicians, tell us about what you like and dislike about fundraising, or what you know about it. And one of my favorites is that I don't ask you, meaning the development professionals, to help me with my work. And I think we have to keep this in mind when we're talking with anyone within our institutions, that we're one of the few that actually do this, that our work is dependent on the participation of others. And of course, the one I get the most is, I don't have the time. Now, over the years, I've interpreted that meaning, I don't like to ask for money, I don't know how to fundraise, I really don't know wealthy people, and if you're going to get me involved in this, you better hold my hand, please. So they really don't have the time. So how do we address that? It's being as specific as possible in trying to engage them, and knowing that for a high degree, we're going to have to lead them in this endeavor. Lenny, since you're the practitioner and I'm just a mere consultant here, I thought that you might lead us through the common mistakes that development offices and foundations make in engaging physicians, if you will. Thank you.
I will, and you know, I think we have to try to keep them focused on their mission and on their work. That's where their real passion comes through, and that's what people want to give to. And I think when we try to impose too rigid of a standard, we try to get it educating, 1,200 physicians and talking to them about rigid goals or specific things that they need to do. We've been more successful in finding individual champions for each service line or each facility, people who believe in the work and are passionate about it and who can articulate it, trying to do it one-on-one through relationship development and not so much lecture and formal presentation, and not imposing too much rigidity. As I said, trying to really treat them as an individual volunteer, as an individual donor, get to know them, cultivate the relationship, and then plug them in where they can help you with families and individuals who have an interest in their particular service line or their particular area of work. And, I think engaging them in a personal one-on-one relationship, as you do with all your other volunteers and donors, is really the key.
I would just comment on one other thing, and that is really one of the more upsetting things that development staffs will do is, particularly on a handoff situation from one development officer to another, or assigning a new development officer, is the lack of communication with the physician. So a new development officer shows up at their office without any warning. They haven't, in the interim, months have gone by, certainly at least weeks, without any communication from the development office. And this really turns the physician off. They begin to really question, are we dealing with professionals here?
Ralph, the other bullets on that next slide really speak to, I think, what we hear sometimes is frustration from the donor community when thinking about development offices is the lack of follow-through, the lack of coordination, lack of communication, which you speak to in terms of the handoff consideration with physicians. And then the other really important piece is obviously everybody feels like their program and service is the most important one on the planet. So to be clear that it fits with your institutional priorities before you start making promises of program support. If you're grant making out of one side of your operation, to make sure that you really have the latitude to support those programs before you make big commitments, there's no faster way to turn off a physician than that.
Thank you, Lenny. So let's get the best practices for strategic engagement. And we're going to start, again, I mentioned this at the beginning of our presentation, with really a macro view of how would you really engage a medical staff. Well, the difficulty is you can't. So what we're obliged to do is to inform them about our work, and we're suggesting 2 or 3 points here that need to be repeated constantly to the medical staff when you have the ability to get them in either smaller groups or in a larger group, address them, or certainly in written communications. So start with emphasizing fundraising as an institutional responsibility. This is obviously much less difficult if we have the administration on our side. If we don't, we're going to be able to make minimal gains throughout the institution and with the medical staff. But if the administration walks the walk and talks the talk, then our job is a bit easier. Explain our role as development or foundation in pursuing gifts to the institution. What do we do? And then finally, and we could use this as a bit of a smile on the physician's face, admit the fact that, yes, our work depends on your cooperation, unlike your work. Your work depends on our cooperation. If we intersect at all, we are helping you in raising money to support your particular area of work. So what if we had the opportunity to address the medical staff? How might that happen, and what would be the best practice? Well, we hear from a number of our clients that if the venue of grand rounds is available to you, that's the best avenue. And in order for that to happen, we have to partner and get as a friend and colleague the medical director, because if that's not the case, then our chances of getting on the agenda are greatly diminished. And I would point out in this area of a venue or any venue, if this isn't open to you, then it's really going to become a department-to-department kind of presentation. They work best after this. But I would point out that the use of data when talking with physicians, concise data, is really important, because you can see a doctor's face light up. It's just like they're reading your high blood pressure chart. They zero in on this. They're used to seeing data. So this is one example, again from GG+A, of a chart that might be used in front of a medical staff. And what's this show? It shows the increase in grateful patient giving. That's an education piece right there. And it also shows how physicians have given over time. Now, some of you may be thinking, well, gee, physicians are going to look at this and say, there's a chasm. Obviously, we don't give as much. We've seen this, the exact opposite reaction. When you point out that we're dealing with a $200 million figure there, that physicians ooh and ah at that their colleagues around the country, and perhaps even at your institution, are giving at extraordinary levels, and combined, they're giving a great deal amount of support to the various institutions that they work with. So let's dig down a little bit farther, and this is really how we start to engage physicians at any significant level. And we really believe in the stars and silos, identification of stars and silos as key to that. And the goal is to identify physician champions. Lenny, comments on this, your success?
We obviously have high visibility programs, neurosciences, cancer, maternal fetal medicine, pediatrics, where we're growing, where we have a strong growth agenda. And we have gone out and found physician champions in each of those clinical areas, 2 to 3 people who are comfortable, who are passionate and articulate, that we've developed a one-on-one relationship with. And they have been key at helping us work with families and articulate the vision. I think you have to be careful if it's not the department head or the chair, that you're following sort of the institutional politics and you're letting their boss or their supervisors know they're helping, that you're using them, and give them credit. So you're being very transparent about what you're doing, and you're not excluding any other colleagues. You just have that personal one-on-one relationship with those 2 to 3 who become your go-to people.
Lenny, that's a great point. The politics of every healthcare institution can be very deep, and you don't want to turn anyone off or create an obstacle, an unneeded obstacle, rather than winning a friend over in a physician chair that may not be the star of that particular discipline. A common practice among our clients, once they've identified physician champions, is to form some sort of physician fundraising committee. And this is probably the most common in campaigns. Those that really work over the course of a campaign many times become a standing committee following the campaign. And the reason why many of these committees fail or dry up in terms of their effectiveness is largely due to the complacency on our part as development officers. We're assuming that these committees start running by themselves, and there is no substitute for the fact that we really lead these committees, and we really set the agendas, and we really focus them in on the areas within the campaign or within ongoing fundraising that really they're going to be the best help to support.
I'll just add a comment here. We've had every iteration of physician engagement on committees, whether it's 1 or 2 on an overarching cabinet, or whether we've had separate subcommittees for just physician campaigns. And interesting story, we had a very well-respected pediatric surgeon. We endowed a chair for him, and he personally made a lead gift for that chair, and then he created a 3-page list of people who he thought were prospects, both physicians and grateful families, that would give. And it was probably one of our most successful small initiatives. We raised $2.5 million in about 18 months, and there were almost no, everyone that we reached out to supported it in some way. And I really think it was because of his unbelievable credibility and his willingness to make a lead gift. And he didn't go on all those visits with the development team, but he did help open the door. And oftentimes we got our foot in that door just because he had made the initial approach, and he carried so much credibility.
Thank you, Lenny. One of the really the big piece of feedback we get from physicians is that I think the development officer that's assigned to us, our department, or I work with really doesn't know very much about what we do. And it gets back to the rhetorical questions we asked earlier in the presentation. How do we really show our respect for this extraordinary volunteer that's in front of us that we want to engage? So the idea of learning about that physician and about the service they provide and what their relationship is to the institution is very, very critical to our building a strong relationship with that physician. And I don't think this is ever too late. If a development officer senses that their relationship with the physician is cold or going downhill, perhaps a view of that physician's program, a review of that physician's program, and what the physician has meant to the institution, so the next time you meet with them, you could start the conversation by giving them a sense of what you know about their work. I think Lenny really underscored this earlier. That's so important to refocus them and to know that they're important to the institution because of what they do, and that the fundraising is going to be another thing that to add to that. But the central focus is their work as healers. So it's never too late to incorporate this into your arsenal when working with a physician. So during your staff meetings with a physician, explain your role if you're new, or re-explain it if they don't understand it if you've met with them a few times. Keep to an agenda. Agree to next steps. Email results to the physician. They actually respond better to emails. And then execute those steps so you have something to talk about and the next time that you get together. We find that over time in my relationship with physicians that if you stick to this, your meetings will be shorter. And they respect that. They respect the fact that you're respecting their time. And we're hitting on very key issues here. And we don't need to spend the full half hour or 45 minutes. We need to spend 10 minutes in reviewing of what's happened and what do you want me to do next. Lenny, any comments?
No, I think, to stay focused, to listen, and to be responsive. Just if you can keep it brief and stay on task, to your point, following an agenda, and, work on the one-on-one. Make it real for them.
So we're heading to, all of this activity obviously is heading toward getting physicians involved in grateful patient fundraising. So let me just talk to you as a consultant about some of the things we see about grateful patient fundraising and programs. One, we see many of these programs that are on the books, but very few that are operationally significant. That lip service is being really done to their implementation. It's usually a staff issue. We don't have the staff to really support these programs in a very significant way. The programs, even the programs that have had traction that we've seen, have overlooked or understated the role of physicians in implementing the program. In other words, they brought the physician in too late, and that causes some problems. Or the physician really doesn't understand the scope of the program. And finally, what's changed in our fundraising, our grateful patient fundraising? Well, really two things. The implementation of HIPAA over the last decade, and then finally wealth screenings, which many of the institutions that are participating today do on a daily basis, and really raises our ability to have a grateful patient program if it's used correctly. So let's go back to the staff and talk about engaging a physician in grateful patient fundraising. What might be some questions if you're a newly assigned staff in getting a sense of where that physician is coming from and what's their level of comfort and concern about fundraising. You might ask about what's worked well with the previous development staff person, and you might get an earful on this. but at least you'll get an earful that's useful in helping you develop strategies to avoid or to build upon. Really talking about what was the area that a standout success that they may have had with a grateful patient. And then it's fair game to talk about their giving to the institution. You find out a lot about where the physician is coming from, particularly if they're jaundiced towards the institution at that point. Remember, we're not asking you to solicit the physician at this point. Just talk about his relationship of giving to the institution. Am I correct in saying that, Lenny?
That's right. That's correct.
How about working with a novice physician, somebody that you want to engage, a novice physician volunteer? I like to start with this question. Are you aware of the opportunities presented by HIPAA, we spelled it wrong there after all these years of looking at it, to identify and engage grateful patients in philanthropy? You notice I use the term opportunity, and that sort of cuts the legs out of the negativity that many physicians have when they hear about HIPAA. Some of them use it as a weapon. Oh, HIPAA prevents me from participating, can't do it. Sort of like some of the legal departments we work with within our institutions, where they start from no and go from there. Now we're talking about opportunities presented by HIPAA. And what might those be? Well, doctor, it really helps us define much more clearly what we can do with a grateful patient. And that signifies that anything that you're going to do after that, working with that physician, is within the HIPAA guidelines. So you're not telling them something that's out of the ordinary or illicit. I like to, and Lenny, I know this is true of you too, talk about grateful patient successes and really using another colleague doctor as an example. And then finally, asking the physician, where in that process might you need support? Rather than saying, what's your comfort level, but where in the process might you need support? Again, almost going back to the question of how best can I work with you? And suggestion for data in working with physicians one-on-one, we find this to be very intriguing. This is the most up-to-date one. But again, how important are grateful patients to our fundraising? Well, doctor, I want to show you an example of how grateful patient fundraising has absolutely soared over the last 6 or 7 years. We'd like to add 2 more tools to engaging physicians that could be used by any of the development staff. We want to, again, focus and focus down, dig down on the importance of individual donors in philanthropy. And last but not least, stressing the donor's point of view. This is a hurdle for most volunteers, as you know, and physicians in general, because Lenny mentioned they're all concerned about their program. They think it's the center of the world, and to many of them it is. But they don't understand the donor's point of view. Where's the donor coming from? It's almost as difficult for them to understand that as it is for them to understand that we're asking them to help us do our job. So with that in mind, this is one slide that I like to use with physicians in talking about the importance of individuals for fundraising. And it clearly lays out the importance of individuals in all those areas, in fundraising in general, in campaigns, in decision-making, and it states flat out, and we get the most questions about the last bullets. You really mean corporations don't give that much money? In our academic settings, I always remind the physicians or the physician researcher, where have your chairs come from? Could you name one chair that's named after a corporation? And it's interesting that they realize that they've come from individual donors. Another graphic, a piece of data that is very interesting in looking at individual giving components, and this totals giving from individuals and bequests and family foundations. Finally, why do donors, what's the donor's point of view? Because the question, and Lenny, you might comment on this, why would donors give to my program? I really don't know anybody that's interested in doing that. Why would they give to our program? And what we find is telling them why donors give really opens the eyes of physicians. They've never thought of it that way. They never thought that they might be making someone's day by indicating that you could give to the piece of research or programmatic services. Go ahead, Lenny.
I think that's a great point, Ralph, and every single one of us have examples in our history where a well-intentioned physician or nurse talked to a family at the bedside who wanted to give back and make a difference. And they said, well, you know, our staff could use a pizza party, or we need a new toaster for the unit. And we have worked very hard to educate our staff, and it's been constant, and physicians to simply say, hey, would you be open to a phone call from the foundation? And we set up a lead process, and where you had an individual who maybe in the past bought a toaster, and then the foundation was able to get to them and turned it into a $2 or $3 million gift. And if you can tell those stories, you know, this individual was here and fed families every month for 7 years, and finally we met with them and they gave a $3 million gift. So I think people are well-intentioned, but they are afraid and they don't know where to begin. So just by creating simple language for them to say, hey, would you be open to a call from our team, then that, again, opens the door for us to begin to develop that relationship and lead a family in a whole new way.
And just to stress that the physician is unaware of the donor's point of view. And when this is hammered home and presented to them, they begin to think of it differently. One of the things that I often use when talking with physicians who have the idea that say, I don't know any rich people, and I don't know how to solicit rich people. I always say, doctor, in your neighborhood, I'm sure you're on every giving list that there is. Just because you're a doctor. And they understand that totally. They agree with that. Yeah, you know, they don't understand I'm a pediatrician and I don't make that much money. But they see that MD after my name and I get solicited for everything. Well, and I say, doesn't it really annoy you when you think about you're not even interested in this program and they're soliciting you for it? Yes, it certainly does. Well, in terms of giving to this institution and your program, there are people out there who are interested. And you're really a key factor in soliciting that kind of information or encouraging that kind of information. And I think they get it under those circumstances. Okay, let's summarize some key areas for you. I think throughout the presentation, we've underscored in an obtuse way, perhaps, that physician engagement fundraising really takes staff time and planning. We used to have an old platitude that we used in another consulting company that I work with that we used to say we can point you the way but not spare you the journey, and it's very true here. If we're thinking this is a quick fix, we're really, really wrong. Getting back to the campaign, one of the things that we see with physician committees is frequently they're organized because the development office thinks this is a shortcut, that somehow the physician committee is going to substitute for one-on-one activity with the physician champion. It just doesn't work that way. Physician engagement is not self-perpetuating. It requires constant attention. They're not going to be the constant teachers of their mentor, their other physicians in fundraising unless they're asked to do it and shown the way. They're mentoring in the best ways to treat patients. Empathy on our part is key. Empathy and knowledge about what they do and showing that we care about what they do and how important it is to the institution. Without them, we wouldn't have a case for support. physician volunteers are very unique and have very unique capabilities. And we understand this when working with other volunteers. We don't group them all together. And yet, when it comes to physicians, we have a tendency to say, group them all together or treat them as part of the family, that they're obligated to work with us. So it's not a simple equation. I don't think we painted one, but we think the attention to this really is something that can raise the level of philanthropy across your institution. Lenny, any parting remarks?
No, I think that pretty much summarizes it. And just to keep in mind, again, it's really all about the one-on-one relationship, just as you do with your own donors and your volunteers, that physicians need to be treated the same way, and really getting at the heart of what motivates and drives them, and then how you can maximize that within your own operation.
Since we have a few minutes, let me answer a couple of questions that we have. One, I think it's a very good question, a very realistic question, but it's a loaded question. What's the use of lay volunteers? Are volunteers perhaps on the foundation board or development committee, development board in engaging physicians? It's the good, the bad, and the ugly. We have to be very, very careful about this. As physicians can really, their presence on a committee can really, really legitimize fundraising. A lay person, not a physician, asking them to be engaged can be a loaded dice. The best I've seen work is where someone who is has the title, in other words, chairman of the board, that sort of thing, who addresses the physicians and indicates that the volunteers are with them, they're behind them, not creating an expectation or not handing down a mandate. Certainly a big donor, the physicians want to celebrate that big donor as much as anyone in the institution. So if you have an extraordinary donor, and that's all relative to the institution that you represent, can you place that donor in front of the physicians and ask that donor to encourage physicians' engagement? Yes, but they have to do it in a very, very sensitive way. The horror stories I could tell you about this is having a volunteer go before the physicians and basically mandating their participation, or saying, you're doctors, you should be involved in this. And that's not taken very well. So that requires us to really be joined at the hip with that particular volunteer. The physicians do appreciate hearing good words from folks that they know have been involved with their institution. And if they represent the same sensitivity that we've recommended in the course of the conversation, we think it's a good idea. Otherwise, you might keep them away. And certainly that in a committee, in a fundraising committee that a physician might be a member of, it's usually the physician that gets the attention and not the other way around.
And we just got another question in asking if, Ralph, you could maybe elaborate on more examples of opportunities available now due to or because of the HIPAA regulations.
First and foremost, I would hope that every development staff person that has a very high degree of knowledge of what HIPAA allows and what they do not allow. So when we talk about opportunities, we're clear about that. But the opportunities we see is, first and foremost, at a very, very macro level, is that, yes, you can engage grateful patients. They're not off limits to us. It's got to be done in a key way, and it shows the sensitivity of the institution to keeping confidentiality, and it also shows the sensitivity of the development office in supporting that policy. So the opportunities we see are within really the guidelines of HIPAA, and really demonstrating that to the physician that, no, this is not a closed door. This is an opening door. This is a very clear direction. And this, if necessary, an opportunity is to reiterate the role of physicians play in HIPAA. What is their responsibility? That adds to our knowledge, and that adds to and then link that with the opportunity to engage grateful patients in the fundraising process. Lenny, any comments?
Just that we've tried to really tightly link the grateful patient screening tools to our rounding programs with our service excellence teams. Our service excellence teams are out doing daily patient rounding anyway, and our hospital presidents are doing patient rounding, and we've tried to include them when we're screening at a certain level to make sure our hospital presidents are creating touch points. And then through the individual relationships that we have with physicians in the key service lines, we've laid our development program out in the service line focus, and we have champions within each service line, and they've developed individual relationships with the physicians who are helping with the screening grateful patient processes. It's a very slow process for follow-up, and we've been studying what's happening around the country, and we've developed an algorithm that we're using that starts with patient rounding and then moves into generic letters. You know, recently you were a patient in our facility. We hope you enjoyed your stay. Thank you for choosing us. Touch point type correspondence, and then ultimately results in phone calls.
We have a question that I thought would occur, and this is, please offer some ideas to successfully encourage current and retired physicians as major gift donors, not just annual fund supporters. How about, and added, how about professional and non-physician staff? Well, let me tackle, and one of the reasons why we haven't really focused on this in the presentation is, and I know Lenny and I agree on this totally, that in order to really engage a physician in major gift consideration is just like engaging any other major gift prospect. And getting them engaged, we always say, you know, those of us that are old enough remember the 5 I's of fundraising: information, the identification, information, interest, involvement, and investment. Well, we are involving the physician. Those that become involved are more likely to be open to a major gift consideration because they understand what the needs, what the real needs are, and why people are giving, and they consider it themselves. I could tell you story after story about clients who have started programs of physician engagement and have said that they have seen physicians offer up major gifts because of it. Now, and I think Lenny agrees with me that when we're trying to engage physicians, we don't want to put in front of them, you must be a donor too.
One thing we ran into with retired physicians, just speaking to the first part of the question, a sense of social isolation that those retired physicians had once they left our system. And we started with a social event where we invited them to see a brand new outpatient facility that we had built, and the medical director was the person who was the host. And we actually spoke and talked about the new building and what it meant, but we used it as an opportunity to create some social connections and tie them back to the mission. And then we asked them to specifically begin to engage in the idea of volunteering in a patient family education center. And we had 10 or so who signed up with their spouses to come and volunteer 4 hours to 10 hours a week, helping other families navigate. And so to the point of engagement and getting them back re-involved, we were successful in doing that because they have a sense of isolation and depression, having lost everything that they were connected to in their lives. And many of them we've been able to bring into our Heritage Society and have them work with us on irrevocable estate commitments. That's been our biggest new pickup with retired physicians. We haven't quite gotten there with retired employees, but we're going to try a similar model.
My final comment on this is when you're trying to engage anyone in a major gift effort, there are certain tactics. Engagement is one. We would do a lay volunteer might be invited on the board and might be invited to participate in solicitations. There are slightly different tactics involved in engaging physicians, but until we really engage them, we have really not a leg to stand on to talk about a major gift. Lenny, I'm going to give you either a softball or a hardball here, depending upon how you view it. But we have a great question, and given your background, I'd like you to respond, and that is, have you explored the concept of utilizing the nursing staff in grateful patient efforts?
Oh, absolutely, yes. We think they're the front line to it. It's been a 7-year journey of educating them really on who we are and how the development team supports the mission and the work of the hospital. We've got direct line staff now serving on their committees. We are having them welcome and introduce people to their units on tours. And we have a new process where anytime we do any event at all, we have 2 representatives from the clinical areas who come to those events. And it's part of their goals, where their president of their hospital has rolled down goals, cascading into all of their departments that have philanthropic touch points. And then through Nurses Day and through educational opportunities, we've just tried to get to them on how they refer a patient, how they refer a family. We've done clipboards with all the information on how to provide a referral through the portal, ways to help, but we're mainly trying to break down the barriers of knowledge so that they can get those families into our doors. And then we share the success. I had a family recently, and a nurse did all the palliative care as the child was passing away, provided the referral to me. 8 months later, I was in a constant dialogue with the family, and they just made a $3 million commitment. And I went back to that nurse and said, this is what's happened. This is a beautiful relationship now that we have with this family, and this is going to be a lifelong process. Thank you for the referral. This is what happened. And also promising that nurse, I'm going to take care of this family. I'm not going to put on a sales hat with them. I'm going to be compassionate. I'm going to care for them, and I'm going to take care of them as you would. And really getting at the relationship and the mission and the work, and not worrying so much about the money, and the money comes. If you can develop the relationship right, we have found that the money comes, and then the staff has been frontline in that.
Great. Thank you, Lenny. And we have a few more questions, but in the interest of time, we'll follow up with you, all of our registrants, in an email with the answers to those questions next week. And again, as a reminder, tomorrow afternoon, we'll be sending a recording of the session along with the slides and a short survey to get your feedback. So I wanted to thank you, Ralph and Lenny, and thanks everyone for joining us today. And that's it. Thanks very much.
Thank you all. Thank you all. Lenny, thank you.
Thank you, Ralph. Nice talking to you.